All right.
So I just, I guess, want to talk a little bit about, estimating really a parameter for COVID-19. I'll also talk a little bit about, I guess, why you'd want to do this, and then we'll dive into some details, and very much work in progress. And then also I can, talk a little bit about like the other stuff people are doing out there and data that's available. So yeah, to start with, I think Alex gave me some feedback when I volunteered to work on something for COVID or to present something related to COVID. And then there was some 538 stuff in the channel as well of like how it's impossible to make a model. I think that, it's still really important that individuals should be looking at all this data. And if you look back at like the response in the US, it was led by individuals generally. I mean, obviously, so like I have, a couple tweets up here. One, the first one was a tweet. Sorry, I should be presenting. I just realized. There we go. So is that gonna, are you guys seeing like half of it now?
No, it looks good.
Okay.
I see all of it.
Awesome. So the first one, there was a tweet from a team in Seattle, right, that had sort of seen the first evidence of community transmission. They weren't really supposed to be testing those cases. Obviously, they were epidemiologists, virologists, but they weren't supposed to be testing. They were looking at influenza. That's how they had the samples. But they basically broke the rules and got on Twitter and said, hey, we have some evidence of, cryptic transmission in the Seattle area. And that's what like sort of lit a fire in a lot of, sort of communities very, end of February, beginning of March, right? That's sort of, you can trace back everything that sort of happened in the US largely started with that tweet. For me personally, the thing that I guess I went to bed one night reading about how bad things were in Italy, right? And not through data, just through like people's anecdotal sort of stories about like hospitals being overwhelmed and hard decisions about which patients to save, retired physicians being called back in, stuff like that. And then the next morning I saw this tweet from Mark Hanley, who's somebody, he's a roboticist in the UK that, somebody that I follow in AI follows him. And he just made a very simple plot, right, where he just overlaid everything based off of an offset that was, essentially like the first day where they had more than 2 cases or something. But showing that everybody's sort of following the same trajectory. So why would we not be like Italy? What data is there to show otherwise? And then there was this Medium post by a guy, Thomas Pueo, who's like a viral marketing VC or viral marketing VP at some startup that got huge, right? Got millions, tens of millions of shares and views. And eventually had a bunch of like epidemiologists say, yeah, he's pretty right about all of this stuff. But a lot of that like social distancing, flatten the curve stuff all started with individuals. And a lot of the like this chart in the middle that shows the offset is sort of what the Financial Times shows like every day now. But it the first time was actually just some roboticist on Twitter. So, I mean, I think it's important that, individuals be sort of looking at stuff, because so far we've seen that in this sort of unprecedented times, large institutions don't necessarily move as quickly as they should. So not to say you should believe everything you see on the internet, or that, I'm not going to sit here today, I'm not going to show you some model where I'm like, oh, I've come to completely different conclusions and I'm super accurate about what I think will happen in 6 months. That's not at all what this will be. Anybody that's telling you that is probably lying or just delusional. But it's still really important that people be involved. And, I think also, it's important to be skeptical of, even supposedly peer-reviewed data right now. A lot of people are trying to rush things out, and I've seen some pretty major statistical errors in papers. You know, the hydroxychloroquine paper that came out of France that everybody got really excited about, including the president, it should never have been a paper. It had no controls. It had no, they basically chose an arbitrary stop point after actually submitting a different one when they proposed the study. It had it's just a terrible paper. So basically, you know, just go out and seek things and be skeptical of everything. It's a good time to brush up on statistics. Okay, anyway, so moving on though. So, you know, you had all these individuals sort of raise the alarm, but now there are all these great models out there. You have a bunch of, you know, big institutions that are paying attention, have research teams and grad students go try and pull all the right parameters and put them in their models and make the best predictions they can and run a bunch of different scenarios. So the issue is that, you know, all of these are still have fixed parameters. So there's these complicated models people have built over the past 100 years, or I guess like 70 years, but still decades. But, you know, they need the correct parameters in order to be accurate. And no matter how complicated of a model it is, you know, how many different like compartments there are, it still needs good parameters. It's more important than anything else. And so, you know, contact rate is like the big question right now, right? That's what we all try to change. That's why we're all at home, is because we're going to reduce the contact rate. But we don't really have any good estimates for what that was, what it will be, how we can affect it. You know, whenever you see most of these models, they make some sort of assumptions about what the contact rate is, and then they run multiple scenarios. And furthermore, there's not only like no data on it, there's not really a consensus on what the data is, like where you would get that data, right? So infection fatality rate, nobody knows what it is because we don't know how many people have been tested. We don't know how many people are infected because our testing's no good. So we don't actually know, you know, what the denominator is for the number of people that have died over the number of people who have been infected. But we don't know how many people are infected. But we know how to calculate it, and we know what data we can get. And as we start to get more testing data, there's ways that you can back into that a little bit more effectively. But the point is with contact rate, we're actually more, you know, if we want to be able to measure this and act on it in real time, this is actually more of a like modern sort of big data problem than it is like the classic epidemiology problem. In that we have, you know, a whole bunch of data from all over the world. We could be looking at traffic cameras. We could be looking at traffic data. We could look at pollution. We could look at so many things. They're going to give us differing levels of lags. They're going to be differing levels of noise, all sorts of things. But one of the, you know, immediate and probably most direct ways to look at it is cell phone data. It's difficult to get, but it's out there. And which is a whole nother discussion about how like this whole crisis is revealing our like inability to use data effectively as a society, and like how we don't have good data markets and everything else. Because like Google has most of the data required to figure out a lot of this stuff. And you see these little snippets of like a news article about how there's a smart thermometer out there, and they made a dashboard to show where people are like having high fevers. That data should be, everybody that's trying to do anything should be getting that data. Like that data should be public, or you should be able to purchase it in some cheap way, but we just don't have, there's a whole nother sort of economic problem of how data is shared in the United States. Anyway, but I happen to sign up and get a license to have access to the SafeGraph data, which is really neat. I mean, this is the amount of data that I'm using. I would have had to pay them millions of dollars to use if I was a normal, just like, hey, I'm going to go try and help Walmart out. They would charge me an enormous amount of money for this. So they have, right now, if you go to their website and sign up, you can get like different data on people, how many people are visiting various places of interest, like actual specific locations, and not just like places of interest as in open maps or places of interest, but every single store. it's a lot of data. But one of the things they have is social distancing data, which is basically, has some different things, but the most important things are just median time at home per day, and then the percentage of the sample who didn't leave home in a given day. So those are the main things that they're there to work with, or the easiest to work with. So the research question here is basically, does social distancing affect contact rate? We all pretty much think it does. So far, it looks like that based on what we've seen with fall off in daily cases and deaths and everything in various countries. The question then is how much? How much social distancing, and to some degree, which social distancing? All those things will need to be figured out if we're going to sort of manage this problem for the next year, 18 months, whatever it is. But it means that we need to know the daily infections to match daily social distancing data. I mean, you can try and do weekly, but in that case, you don't really have a lot of, you have less data points because stuff sort of flipped quickly in a lot of places. So they want to get daily. So to do that, what I've been trying to do is just a simplified epidemiological model. Instead of using sort of the more complicated compartmental model, this is essentially it's a 2-compartment model, but there's no, I guess it just recycles. So there's replacement. So basically, the goal is to estimate the infection rate, not the reproductive number. So we're looking to try to figure out the number of new infections per day as a ratio of the existing infectious population. So that can be used as sort of the dependent variable, where the social distancing metrics are the independent variable. So if we're going to know the number of new infections per day as a ratio of the existing infectious population, then for every day we have to know how many new infections occurred that day, and we have to know how many people were infectious and circulating the population that day. The data that's available for figuring out are cases and deaths, right? That's what every data set on the internet is, just cases and deaths. Testing's starting to show up, mainly at state level. So to do that, we need to somehow, we need to go from those cases back, right? Or deaths back into infections. So we need to calculate those backwards. There's a lot of reasons to use cases instead of deaths. Essentially, deaths just open you, while you just have to worry about a lot more sort of unknown parameters. To calculate from deaths, right? You have to know the mortality rate, which gets you into things in terms of, like, you have to worry about the demographics of the people involved. You have to worry about whether or not hospitals are overwhelmed and everything else. Whereas if you stick to cases, you're basically just dealing with how many people were completely asymptomatic and how much under testing was there. So it's sort of 2 assumptions or estimates depending on how you look at it. So basically, the way that I was trying to approach this is that you can use the known cases to estimate new infections at previous time points. So then you use those estimated disease mechanics to calculate the infectious population going forward. So you go back and say, if there were a certain number of people who were infected on day 9, then some of them will still be infected on day 10 and 12, et cetera. And eventually some of them will recover. And so to do that, you need to know what the distribution of incubation times are, what the distribution of the infectious period is, and then the percentage of infections that become cases, which is essentially that sort of under, so you're going to need to know also the percentage of infections that become cases, which is, the number of infections that either, or severe enough that they get tested, basically. And then there's a sort of big assumption, right, which was much more reasonable when I first started this, and is becoming less, which was that all individuals are susceptible throughout, right? So we're not really worrying about whether or not somebody's been previously exposed and now is resistant. So when we were looking at much smaller numbers of infected people, that's pretty safe assumption. Now it's becoming less so. So how do you estimate the number of infections per day? So you basically assume cases show up about the time there's the onset of infections. So people, or sorry, not of infections, of symptoms, right? So pretty much when incubation ends, if somebody was going to be symptomatic, then they presumably get tested somewhere near that. Obviously, there's been various delays in testing and everything else. But for each one of those cases, you then you just multiply by 1 over the percent of infections that progress to case. So if you assume that, say, 60% of cases, of infections end up becoming cases, then you just do 1 over 0.6, and that gets you the total number of infections. So I used a paper that was based off of sort of population data in China that estimated the number of asymptomatic or unreported cases there. So that gives me that parameter. And then, so for each one of those infections, you can generate a time offset from the distribution of incubation times. So for each one, you basically say, okay, you draw from that distribution. And so that's all been parameterized in various papers. So you get those the parameters for that distribution, and then just sort of call it. So if you say there were 60 new infections based on the cases the cases that we see today, then we'll distribute them into the past over with a random amount of time drawn from that distribution. And so then basically each one of those new infections starts an incubation, right? And then each day along its trajectory, it either will remain in incubation or it progresses to an active infection. So for that specific infection, the probability of progression is 1 minus the survival function on that day over the the value of the survival function on the previous day. So we're just basically, looking at making sure that for the whole population of infections, their overall duration continues to match the distribution of incubation times. And every time one of those incubation ends, then you just have a new infection. And then those sort of progress the same way, where they, stochastically fall out, or basically recover or die. And also sort of any new cases that occur during that time are removed from that pool randomly. So some people that are at day 5 are removed, some people that are at day 2. But the cases are pulled out of the infectious population. So that also reduces it. So that's the model setup. Let's see, I need to exit. There we go. So that's all done in a couple different scripts that would be even more boring to go through than having me talk about it in a PowerPoint. So we'll not go look at those. So, but the output of that then is that we end up having this epidemiological data that has basically the number of sort of the size of the latent population, size of the infectious population for each day, and can be matched up with the actual data at a county level in the US of the number of cases and deaths. And then we can go get this social distancing data that I talked about before, which, yeah, I guess I'll just also just show what that is. So yeah, basically this gives us, for each date, the number of minutes that, the median number of minutes that each person spent at home, the percentage, and then the percentage staying home. And these are all at county levels. So they have these at census block group level, and then, I've aggregated them up, adjusted for their sampling bias, and then brought them in here at the county level. So we take that plus the, epidemiological data, and there's no great outcomes here, I should just say. This is all thrown together this afternoon. So basically, you can plot it, and not surprisingly, you know, the number of people, the percentage of people staying home increases, the, you know, number of infections, the percentage of new infections goes down, right? So overall, it's basically, you know, every additional 10% of the population that stays at home all day results in about 5% less new infections, right? So if there's 1,000 people, right, this is saying if there's 1,000 people that are infected, then tomorrow there will be 500 new infections over here, right? And we're somewhere more around like 400. And for every additional 10% of people that stay home, we reduce that by, you know, 50 people. I just looked at the same thing with the, you know, median home dwell time, right? So instead of the percentage of people that stay home, this is the median amount of time spent at home as a percentage of the day. I wanted to get these both in percentages. But so basically this is just the number of minutes over the number of minutes in a day. So, you know, most people are spending about 50 to 5% of their time, 60% of their time at home. And then, yeah, so we can also look at this as a time series to try to see whether or not, you know, there's like inflection points that match. This isn't super informative, I would say, but, you know, overall you're seeing that, yeah, so sort of the infection rate as a percentage of the infectious population per day was bouncing around. Sorry, this is not a very good, let's see if I can bring this up. Juke your notebook. It's cool. But here we go. So yeah, so, you know, sort of virus was largely bouncing around relatively uninhibited for the first part of March. This, I don't know, maybe is from some starting upticks in testing. But then, you know, you can see people were progressively staying at home more. And, you know, there's been a fall off in rate. There's also, you know, try to look at this at a county level. It gets relatively ugly quite fast. But yeah, that's just sort of a starting point. You know, obviously the next steps from this would be to try to actually go back and estimate the original parameters. So there's some that I was just sort of like, okay, there's papers out there that say, you know, what the incubation time is, what the percentage of, actually, I probably keep incubation time because that's probably pretty well established. But for instance, like the percentage of infections that progress the cases, right? That's a big unknown right now. You know, so it was estimated from one study that was pretty similar to this, right? Trying to estimate sort of latent variables in China. So I would probably try to go back and re-estimate that for the US. There's a lot of different ways to do that with Bayesian statistics, that you can set up a model and essentially use the data that you do have available to estimate certain parameters that are not you know, readily visible, and use the actual mechanics of the model to help you sort of get better ranges for those, rather than just sort of trying to directly estimate them. Anyway, so that's basically you know, what there is to show from that. The other thing I just want to say, let's see, you know, bunch of fancy models out there. If you haven't seen them on the internet, I think most people have probably seen this one, IHME one. There's this one, or yeah, this Columbia one. This is from the same group that I got some of my parameters from. But this, sort of lets you choose your own different scenario, and then is, at county level. So you can see that Knoxville is looking pretty good. And this one also takes into account different like dynamic patterns of social distancing, and then has all of the various comorbidities and everything else built in as well. So yeah, so this is, this is what, if you have a whole bunch of different sort of a complicated model and you can feed a bunch of different parameters into it, you can get really, really detailed stuff. But I think, yeah, right now I still have to spend some time trying to figure out what those parameters actually are. Yeah, so then there's also, some interesting data sources. If you're interested in looking at doing anything around COVID, there's now this COVID tracking project has state level data, yeah, via API, I mean, really via file via API. And then Johns Hopkins has all the data that's behind their dashboard on a GitHub site, so you can pull that down as well. There's other stuff out there. A lot of it is either, not entirely public, or doesn't get updated regularly. I'd say, if you actually, want to help out in all this, like my greatest contribution in this, for this project, I think at this point will be the fact that I have like a pretty established workflow for getting this SafeGraph data like cleaned up and aggregated and joined to Johns Hopkins data. And that's what I will be, like pasting back into the Slack channel for all the people that are using it. Not any sort of like grand scientific outcomes. And if you look at a lot of the stuff, like, so for instance, this data is being scraped from state websites. And so there's a lot of opportunities, if you go out and look, to help sort of just find data, or build data manually. Kaggle, I think, has like data set competitions going on as well, if you're interested in that sort of thing. So that's all I've got. If there's questions.
Cool. I guess I'll start. So I guess it's kind of more of an opinion when you kind of think about related to some of the challenges you've seen so far with data. You said data management and market. What do you foresee as some of the problems that are going to come into play with like tracing efforts when we're already not able to share some of the other information really well? What are some of the things you kind of think that you're going to have to kind of figure out or watch for?
I mean, yeah, the main thing is privacy, or the illusion of privacy, right? So we can't get, well, yeah, let's go back to like tracing data. So for instance, the company I'm looking at, SafeGraph, or I'm using data from SafeGraph, gets a sample and it's anonymized, but it's definitely being used to like, their normal market is to be able to use that data to like figure out at a census block level how to market to people. And, cell phone companies sell much more specific data, so that you get marketing because you like walked into a Target, you're going to get marketing about Target or a competitor. So you're being tracked all the time. Like, I don't know how many, I mean, all the weather, like the value proposition of every weather app is that it's a tracker. It has location turned on and it has a reason to ping every 10 or 15 minutes. So you're being tracked by all your weather apps. So our privacy doesn't exist, but there's still this illusion of privacy. So yeah, I mean, people don't want to have the government tracking their location for contact tracing. I don't really see a way to, I mean, I know like Google and Apple supposedly we're gonna sort of, between the two, phone operating systems, right, track everybody, and then, or like, I guess have people opt in, and then keep it anonymous and then de-anonymize it later or something. I mean, I don't know. I think if people opt in, that'll work, but you have to get enough people to opt in to get sort of like a network effect going on there.
Yeah, there's a similar tracing effort by MIT, this app, but that was kind of my thing. Is like I started using it, but like it says load public data set, and then I load it, and then there's like nothing because no one else in Knoxville is using it because no one knows about it, right? And so it's interesting because I think you opt in and you can give your location data once every 5 minutes or whatever. It stores it, and it's all these things, legalese to kind of say, hey, we're trying to not steal everything you have, but this is what it is. But yeah, but it's also interesting clunky interface too of like how you're actually uploading information, and then like in comparison to some of the contact tracing stuff that we've seen from like South Korea or other places.
Yeah, I mean, but South Korea's, the Americans wouldn't accept what South Korea's doing.
Right. Yeah. Exactly. Yeah.
Which, so there are like real privacy concerns, I guess. I don't know. We should be concerned about privacy. This probably isn't. We should all realize that it's already sort of gone, I guess, or I don't know. Maybe it's better that advertising companies have it and are using it to make money than the government having it. But yeah, it's really frustrating that there's stuff that we shouldn't be as concerned about. So, for instance, like where are the hospital records for all this in the U.S.? Why do we not have like a relatively public data set of like the cases that have occurred so far? What was the date of admission? Some basic description of some sort of clinical status and progression. Like that should be relatively easy to de-anonymize or to anonymize, de-identify, and then publish, but it hasn't happened. And that's, I think, sort of an issue across the world. And there's also not a good, because there's not a market, there's also not a really good market for like secondary stuff. So here I'm saying like, yeah, I'm, found this data set other people are using, I'm going to go like post some stuff in Slack. Like there's just not, we don't have a good way to work together around this stuff the same way that it exists for like, we need to make more masks. Okay. Somebody just says like, go donate masks here, or like, here's a template, go build it. And I don't think that the volunteerism around software engineering or data science has really been figured out very well. And this also sort of reveals that, but also just that there's not, even if there was money involved, it'd be really hard for the government to just be like, we will pay like, here's $30 million we're going to spend for better data models. And it would just sort of, go out into an existing market and cause things to happen. Whereas they can't just say, we need $30 million worth of plastic face shields.
I think that's one good thing that has come out of this is opening people's eyes to how bad our society's data is, and how much more time we need to invest in providing that data.
Yeah, definitely. Oh, I hope people are noticing. I don't know, just us noticing. Only data focused people are like, whoa. But
well, let me say a few things. First off, I appreciate you guys allowing me to come to your meeting. I live in Lexington, Kentucky, and I'm on your meetup list. And I've intended to come down for a long time, but I've never made it down 75.
Easier this way.
Well, yeah. But anyway, thank you guys so much. One of the things I know I've like, this breaks my heart to see like the data. Well, how, I don't know, sort of unpure, how corrupt the data seems to be. I mean, in terms of like how it's gathered, how things are coded. And, you see, anomalies in the data that can't be just random. Particularly, well, I don't know, there was that time in China back in what, I think it was January or February, when their numbers like all of a sudden doubled because they had just started reporting them in a different way. And it's like, man, I see that on a chart, and I think, there's got to be some way to take into effect this like exogenous effect. But nonetheless, what I have been like really heartened by is some of the like really kind of clever and creative ways people have found to use data. That I did not read the study, but that MIT study that was reported in the Boston Globe yesterday is when I read it, about the sewage, looking for, I guess, virus shells in sewage and making, I mean, now, seriously, I mean, you're having to really pile a whole lot of rocks on top of each other and hope they don't fall. But I mean, that was kind of clever, I mean, to look at sewage. And the other is the study that was in the New England Journal of Medicine a couple of days ago about the maternity hospitals and women who were tested in New York as they came into the maternity hospitals. Those can give us maybe a better, at least a better rough estimate as to how many like asymptomatic cases there are. So for every one that we see as a symptom and count, there's a whole bunch of them that aren't. And that's one of the things that's kind of missing in this because of the selection bias, or the selection bias in the testing has been like completely non-uniform across the country and across the world.
Right. Yeah, I mean, I think that's, I guess what good is that it would be really useful to have all those different data sets sort of flowing together, right? So that you don't just have to like look at a paper here, look at a paper here, look at a paper here and be like, well, maybe the truth's somewhere in the middle. There's, there are ways to unify the information that comes from all those different data sets together.
But also I think that's one of the opportunities. I think this volunteerism is really great because honestly, once it's your job to collect data and you design a web page or a procedure or form for people to check the box and say, okay, this is COVID-19, this is congestive heart failure, whatever. Then I don't know. We've got to be a little bit more holistic in terms of our approach to data like this. I mean, one of the things I've been fascinated by is, and I've really had a difficult time finding up-to-date data on the CDC website on total mortality. But the European, there's a European, it's called mortality monitoring, or European monitoring of excess mortality. Has anybody seen this? It's euromomo.eu. Anyway, the data for week 15 just came out today or this afternoon, and so they list essentially. Oh, let me see. There you go. It's perfect. So you look through there, and first off, the countries that are highlighted are the ones that are in excess of have a Z-score, total mortality Z-score in excess of say 7, which is pretty high. And then you look at pooled deaths for these 24 European countries and different age groups. And obviously 0 to 4, toddler deaths are very, very random looking because there's so few of them compared to total deaths. But if you go down to 65 plus, and then all ages pretty much looks like 65 plus because it's weighted heavily toward people who are over 65 are the ones who are dying and pulling those numbers. So if we look week by week, you see that, and again, this is just 24 European countries, but you see that the weekly mortality can vary seasonally, anywhere from say 50,000 to 70,000 deaths, a week. And you see the flu season in 16-17 was pretty bad. It looks like a double hump around 17-18, and 1918-1919 was kind of light. And then just this week have we started seeing like the peak start to come back down for total mortality in Europe of all ages. And then if you follow the chart down a little farther, you can see country by country. And so what I guess I'm really saying is that the only way to really look at this, I mean, not the only way, but is to look at excess mortality. those deaths that occurred as a result of this that would not have occurred in another year, in another year. And I not to say that any death isn't a horrific thing, but I find like something like this to be a little bit more well, it's a little
Yeah, it's
less
concrete.
biased.
Right. Yeah. You can't hide the fact that there's, or miss the fact that there's
Right.
tens of thousands of people that die and that you wouldn't expect.
Oh yeah. And so, and the other part is, according to this, like a normal flu season, you get a pretty nice broad hump. Here we're seeing something with a little spiky, right? Although it's really difficult. I mean, it's probably not good form to make these kind of assessments over data that's a week old. And we don't know how it's going to end up either. So.
Right.
But anyway, that's I think I don't know. I would love to see more data like this from the CDC.
Yeah, definitely. I mean, once again, that's we really aren't getting. I mean, this sort of data should already be public, right? At a pretty granular level for the United States, regardless of any just how many people die every week. I mean, that's
right.
An important part of what's going on in the country, but
absolutely, yeah. And too, I mean, I don't know, it's not significant. I mean, the numbers aren't big enough to really make that kind of a call, but when you look at, say, ages 5 through 14 and somewhat in the 0 through 4 years, being sequestered at home looks like it's actually dropped the death rate for some cohorts. So, although again, it's dangerous to make these kind of statements. I doubt that they're statistically, I could back it up with any kind of real
those are both
significance. I mean,
those are stochastic processes.
Absolutely, yeah. And also, again, the numbers are pretty small. These are just basically, they're random. You're right. It's a stochastic process.
Yeah, because those are still within what they're saying is 2 standard deviations.
4 Z-scores is the dotted line, the small dotted lines.
Sorry, what was that? You broke up.
They say this is 4 Z-scores. Honestly, I don't see that. I don't see how they get 4 out of that. Unless I'm misreading the okay, no, I'm sorry. The very top line is 4 Z-scores. The normal range, they say, is plus or minus 2 Z-scores.
Yeah.
Okay, that makes sense. But yeah, I would love to see more data like this and see it discussed more frequently as well. So yeah, the other part is, because especially in the first a month ago when they were looking at the Italian data, the number of cases without a single comorbidity were really, really small. I mean, everybody there, and it was surprising too, because I guess with a respiratory virus, people were predicting that COPD would be a comorbidity that would have a much higher percentage of case mortality. But in truth, it was I think it was like heart. There were coronary problems that were most associated with death, and which I found a little bit interesting. I mean, so because of all those things sort of convolved together in this, it's really difficult to say, hey, what exactly was the cause of death? Because you can, because it's difficult to separate those out when you have multiple things that are actually causing the fatality.
Yeah, no, that's death. Using deaths gets as either trying to predict deaths or trying to use the death rates to figure other things out gets very complicated very fast. That's why
absolutely.
I've avoided it so far, just trying to stick to cases.
Yeah. Congratulations.
Yeah, when possible, avoid death.
Yeah. Anyway, I do intend to come down to Knoxville sometime and meet with you guys. Well, once we can do that again. So, but everything else I've got is canceled now, and so I've got time to devote to stuff like this.
Very cool. Yeah, I guess one other question. Question to the audience. Hey, Arlene, I know you've been doing some of the data viz stuff using John Hopkins data set for your Tennessee county by county. Is that right? Arlene? Oh. Maybe she didn't. Arlene, can you hear me?
May have stepped away.
Okay, may have stepped away. Okay.
Yeah.
Yeah, okay. Oh well. Yeah, does anybody have any other questions? Otherwise,
Time to go over to Crafty Bastard.
yeah, that's right. Awesome. Well, thanks everybody for joining in on this. Thanks again, Zach, for putting something together to talk about this. This was a really cool look at some of the things that we think we're doing well, but maybe we're not, and where's opportunities that we might lie that we might be able to get involved with or have questions to see about where this goes, especially in the months ahead. So yeah, thanks again for everybody for coming tonight. Hope you enjoy it. If for next month's, for May, if you're interested in giving a talk, message Josh Rosenberg or I, and you can reach out to us through Slack or message us on Meetup.